Good morning, everyone. Respected seniors, my juniors and colleagues. Today we are here to discuss about the case of a 60-year-old hypertensive male with acute chest pain, which is one of the most common symptoms patients present within the emergency department. Just before starting, as a brief introduction to our department, headed by Dr. Murtaza Ahmed Chishti, chief surgeon, and two surgeons, Dr. Ajay Meena and Dr. Ashish. Dr. Ajay Meena is a recent entry in our department. We have three cardiac anesthetists, Dr. Saurabh, Dr. Ashish Varun, with two perfusionists, physician assistants, and sufficient staff and ICU charge. As our patients firstly present in the emergency department, so I'll first like to invite Dr. Ankita Aggarwal from Department of Emergency Medicine.
Thank you, Dr. Ashish. Good morning, respected teachers, seniors, and my dear colleagues. We're moving forward. On 13th of February, around 2:45 p.m., we received the patient, 60-year-old male, resident of Nara, Rajasthan, farmer by occupation, in our emergency room, with the presenting complaints of chest pain, anxiousness, and sweating, with a one-day history. The patient was triage-read because of his chief complaints, acute chest pain. Primary survey was done. Patient was alert and conscious with patent airway, bilateral air entry present. Blood pressure was 170 by 30 millimeters of mercury in left upper limb. One large bore IV cannula was secured. Glasgow scale was 15 by 15 with random blood sugar 165 mg per deciliter. Patient was injured. Patient was apparently well one day back, then suddenly developed abrupt retrosternal sharp chest pain, which was relating to back. Patient was having a feeling of impending doom with excessive sweating. He started to self-medicate at home, but there were no relieving or aggravating factors seen.
Did the patient say, I haven't been?
So patient was very anxious and he felt as if the world is going to collapse around him. The negative history was taken. There was no history of syncope, vomiting, nausea, hematomesis, fever, pain in abdomen, hemoptysis, cough, palpitations, shortness of breath, altered mental status, drug or any substance abuse, no previous episodes, no trauma or hypermobile joints. So now we have a 60-year-old male, hypertensive with sharp retrosternal chest pain, radiating to back, feeling anxious and sweating. Can anybody enlighten on the differential diagnosis at this point? Cardiovascular, pulmonary, and gastric, GI related. Cardiovascular causes for acute chest pain can be myocarditis, coronary artery disease, valvulopathy, and myopericarditis, aortic dissection, spontaneous coronary artery dissection, carditis, tamponade. Pulmonary causes can be bronchitis, costochondritis, Tay syndrome, herpes zoster, pulmonary embolism, pleuritis, congestive heart failure, pneumonia, effusion, pneumothorax. GI related can be cholecystitis, gastritis, and peptic ulcerations, or esophageal rupture. Now we examine the patient. Patient was moderately built with blood pressure in left upper limb 170 by 50 millimeters of mercury and in right upper limb 60 by 30 millimeters of mercury. Pulses were 90 beats per minute, regular high volume with feeble pulses in right upper limb. All peripheral pulses palpable. Respiratory rate was 20 per minute with SpO2 95% on room air. Patient was hypothermic. Serious examination included not much significant except.
The first slide you mentioned the blood pressure in the left upper limb. Now we all know that standard arm in which blood pressure is measured is right arm. So I'm sure when this patient came, whosoever was in the emergency medicine must have measured the blood pressure in the right arm. Why would you do it in the left? Okay.
IV drip in the right arm. Was there an IV drip in the right arm?
So what? So what? Is there any situation where by choice you will measure the blood pressure in the left arm?
Hemiparesis.
Conditions. What I am trying to say is that if this patient came to the emergency, somebody must have measured the blood pressure in the right upper arm, which was 60 by 30. Then obviously it becomes very, very important to measure it in the other limb also. That is the natural normal sequence.
You said all peripheral pulses palpable. Was there not a differential in the pulse volume or in the pulse?
Sir, in right upper limb, the pulses were feeble.
Isn't that an important thing to mention right here? Feeble pulses in right upper limb. The rest of the limbs, everything else was normal.
So that were not. There was on auscultation, there was a loud grade 3 early diastolic high pitch decrescendo murmur in left third intercostal space. Said that precordium was normal, no visible palpations, apex beat in fifth intercostal space, middle to mid clavicular line, and normal apical.
Can say you want to use auscultation. आजकल वैसे auscultation कौन करता है? Please carry on.
Other systems, the respiratory system, gastrointestinal system, and central nervous system were reportedly within normal limits. There was nothing abnormal found about them. Now to summarize, a 60-year-old male hypertensive with acute sudden onset tearing chest pain relating to the back, focusing on interscapular region with difference in blood pressure in bilateral upper limbs. What are the possibilities?
Multiple possibilities, but one you have narrowed it down to a few conditions now. Okay, it can still be acute coronary syndrome. In fact, that's 50 times or 100 times more common than aortic dissection. That we have to keep in mind. So, but the pointers are more towards dissection because the pain is severe, middle chest radiating to the back, sudden onset, and there is a significant differential between the limbs. Okay.
These are the images.
Sorry, Dipesh, you asked whether blood pressure in the lower limbs was measured or not. Is it required? Because in the right upper limb it is 60 by 30, in the left it is 170 by something. Is it possible that in the lower limbs it may be low?
Yes, sir. So important is whenever you take blood pressure, it is commonly found blood pressure in right upper limb is more than the left, but here it is just opposite to that. So number one, why right upper limb blood pressure was lower than the left upper limb? However, in general rule it should be in opposite order. Number two, if right upper limb blood pressure is low and left is high, then what about the lower limb blood pressure? Whether it is equal to left one or right one? And number three,
can it be less than the left upper limb?
yes, that can be. There are a number of possibilities where you can have lower limb blood pressure less than the upper limb blood pressure as well. So,
no, in this situation where now we are thinking of a dissection, then is it possible that dissection will not involve the left upper limb vessels, but it will involve the abdominal aorta?
It can happen if the dissection is spiral. So it involves brachiocephalic trunks and spirally it dissected the aorta and go down to abdominal aorta and the bilateral femorals. So extensive dissection is starting from the proximal aorta, spirally, where the subclavian artery is originating from the true lumen, and other vessels originating from the false lumen. In that case, you may have low blood pressure in the opposite limb, and one limb may be spread. So in coarctation of aorta, you will have lower blood pressure and lower limb. In that case, you will have radiopulmonary delay and other findings, physical examinations. But again, severe tearing pain starting in the chest, going to back interscapular area, acute onset is victim of probably acute aortic dissection. However, it can happen in acute myocardial infarction as well. Most of the inferior wall MI, they may have associated aortic dissection. So whenever you think that this is a inferior wall MI, you should check blood pressure in both limbs as well as upper and lower limb to exclude dissection of aorta, because few patients of inferior wall MI, they may have associated dissection of aorta, and if you give streptokinase in these patients, that may be disastrous.
Yes, it's true. Actually, it's not very rare to have these dissected patients present purely as myocarditis. Okay? So if you are seeing more commonly the right coronary artery, rightly pointed out, but just because you have a diagnosis of acute myocardial infarction, that doesn't automatically rule out aortic.
I think it's a very important practical lesson for all residents who are posted in emergency, especially emergency medicine, internal medicine, that in any patient where you are thinking of acute coronary event, you must measure the blood pressure in at least both upper limbs and preferably in all four limbs. Very, very important.
So now the next question is, what is the single most important investigation that will help you rule out a type A dissection? You are coming to that. Yes, I'm jumping the gun a little bit, but it's relevant at this point because everything has to be expedited. You have to be thinking about that particular investigation at this stage, not later on. Because
the emergent causes of chest pain were excluded as the patient was triage-read first. The 4 heart-related causes, 2 lung-related causes, and 1 esophageal-related cause. Acute coronary syndrome, aortic dissection, pericarditis or myocarditis, pericardial effusion, cardiac tamponade, pulmonary embolism, pneumothorax, and esophageal perforation. We went ahead with the investigations available in ER, which was ECG, point-of-care ultrasonography, chest X-ray, and trauma. This was the ECG scene.
So sinus tachycardia, like slight sagging in inferior lateral, nothing else. Mild LVS.
This was the chest X-ray scene. Ancillary studies included tropi, which was negative. So the mediastinal widening, which is around in ER, we are only available with PA view of the chest. So more than 8 centimeter transthoracic distance at the aortic knob, which is marked by the point. The ancillary studies included tropi, which was negative, and arterial blood gas analysis, which was within normal. So nothing much significant to see.
You did a tropi, so normally people are doing tropi. What is the difference between the two?
So tropi is more specific. For
Regularly
pattern.
now, tropi. So is that a hard test?
No, sir. We have a machine available, tropi, so we get the values in around 20 minutes time.
So there are 2 types, quantitative and qualitative. So card is available for TROP-T. Commonly we have TROP-T card, which give you a qualitative, positive or negative. However, quantitative value is more for TROP-I, and that will tell you slight rise, even the slight rise that can be detected.
not in the lab.
Both can be done. You have card as well as.
So there's a card as well. Okay. Now, do you have the printout of the arterial blood gas that you're saying is within normal limits?
Sir, I do have the printout.
Ashish, you have the printout? What we had in the, I remember, well, I don't want to let the cat out of the bag too soon, but do you have the printout? I remember this patient had white out. Both lungs were white. Because why? Why did he have that? Because he had acute ventricular failure because of what? Because of acute AR. His diastolic pressure is 30. And if I remember correctly, his PO2 was 47. So can you call that normal? That was in the ward. That was after 1 day of diuresis. Yeah, I don't know this. Please go ahead.
Finally, we did the point of care ultrasonography, and in which, in subcostal view, we saw a flap in the abdominal aorta. So this is the flap.
This is a very, very important investigation.
So this was the flap seen in abdominal.
This was done by the emergency medicine team or by the cardiology team?
So emergency.
Then that's what I thought. Point of care is by the person who's there. Cardiologist will take a few minutes to arrive there.
Absolutely. This is very crucial. Please describe.
So this is investigation available with us in emergency, point of care ultrasonography. We use it for different purposes. For example, blue protocol or rush protocol. We use it for 2D echo screening. The cardiologist also uses it when given a reference for ER. And we can do a lung scan, a heart scan. We can see the IVC.
So for the benefit of others, you need to tell us that at which point the probe was placed where you saw this aorta.
Sir, basically abdominal aorta can be seen in the subcostal view, and you just putting a probe at the subcostal, you can have a parallel view of aorta. This should be clear actually. In the middle of the aorta, you can see a white flap, and if you see the moving frame, it is basically moving with the flow of the blood. So that will tell you this is dissected intimal flap from the aorta. So this is very important to diagnose aortic dissection in emergency. Just by looking the subcostal view and seeing the aorta, abdominal aorta, you can find this one. However, in echocardiography, you can see ascending aorta as well, where you can see the aortic valve as well as ascending aorta, where you can have dissecting flap in emergency only without any further investigation to later stage.
Suppose you put your probe at the subcostal region and the abdominal aorta is normal, there is no flap. Does it rule out dissection?
No,
It doesn't.
it may not be extended to that part of the aorta. Now to summarize, a 60-year-old male hypertensive with acute sudden onset tearing chest pain radiating to the back, difference in blood pressure in bilateral upper limbs with LVH and ECG, troponin negative, chest X-ray with mediastinal widening and a flap in abdominal aorta in subcostal view on a focus machine. Now, the probable diagnosis will be acute coronary syndrome and acute aortic dissection.
Would you like to add acute aortic regurgitation?
Yes.
With the normal ECG now, you're still at normal drop, you're still considering acute coronary syndrome. How often does it happen that the ECG is normal and drop is normal? In ACG?
Sir, in acute coronary syndrome without elevation MI, almost 50% of the ECG may be normal. In acute coronary syndrome with unstable angina. And for troponin test, within 3 hours if you do, it may be negative. But after 3 hours of acute chest pain, it may start rising. So it will take at least 6 hours to rule out. And even we should have a rising titer of troponins that will tell you the diagnosis of acute coronary syndrome. Highly sensitive troponin now available that can tell you earlier possibility of acute coronary syndrome at this phase.
Echo would probably show some renal wall motion abnormality.
Sir, even with echo, you may not find renal wall motion abnormality until unless there is infarct. So initially, you may have diastolic dysfunction in echocardiography. Without that, even then you can have it.
Rule out.
Yeah.
Despite these normal numbers, you can't rule out.
So rising titer, serial ECG and echo and troponin level will tell you the diagnosis of
That it's already more than 24 hours, and probably his onset of pain was more than 24 hours earlier, and drop is negative. Obviously, now we can comfortably rule out acute coronary syndrome.
Yeah.
In fact,
If we have the first possibility of aortic dissection, second
Now with that flap in the abdominal aorta, that the diagnosis of dissection is clinch. Now there's no little doubt. There's no second diagnosis now.
At this point,
One is a very important message for all residents. If you are strongly suspecting an acute coronary event, as Dr. Dipesh said, don't rely on one prop eye or prop T, whatever you're doing. It has to be repeated. Am I correct? Yes. Second, question to both cardiology and cardiac surgery. Suppose the primary event is acute aortic dissection. It can cause a secondary coronary syndrome by blocking the ostia?
Absolutely, yes. Myocardial infarction.
Extending flap can obstruct coronary ostia as well. And after obstruction the coronary ostia, patient may develop acute coronary syndrome afterward, even myocardial infarction as well.
I would like to invite Dr. Arpit from cardiology to enlighten us more. Thank you.
Good morning, everyone. So now I was called in the emergency department for consultation of a 60-year-old male who presented with sudden onset excruciating evening-type chest pain, radiating back and chest pain over 1 year duration, with significant blood pressure difference between both the upper limbs and a diastolic murmur which was hurting near aortic area and the left third intercostal space parasternal. On the basis of this short history, the differential diagnosis which should come to our mind, most probable diagnosis because the pain was a typical diaphragm radiation, the acute coronary syndrome with some complications, aortic dissection, these are the most probable diagnosis. And sometimes other diagnosis which could also present with the same clinical picture could be pericarditis, temporal, valvular heart diseases like supravalvular AS that would present with chest pain and sense of membrane forms above the aortic valve, so unequal blood pressure in the upper limbs, and thromboembolical phenomena. These could also present in the same clinical picture. Just a short slide to help us understand the importance of history to differentiate between different diagnosis that can be made on the basis of history.
If you want, you can skip some of your slides, those that have been already discussed.
This slide suggests to give importance about the history, the quality of symptoms like the acute MI. The patient would present with a typical chest heaviness, with a feeling of pain, squeezing and constricting type chest pain. In pericarditis, the pain would be of a pleuritic type chest pain that is increasing with inspiration, often associated with fever, increasing in supine position. In aortic dissection, it would be a severe excruciating type chest pain, and particular radiation to interscapular aortic dissection. On quick examination to confirm the examination findings, blood pressure difference was found in right upper limb and left upper limb significant, and also lower blood pressures were found in the lower limbs as compared to the left upper limb, which suggests that some obstruction is taking place between the left subclavian artery and the femoral arteries. The pulse rate was of high volume mounting pulse with right upper limb feeble pulses, and all peripheral pulses were passive. Oscillatory finding was same as done by the emergency resident. In the neo-aortic area, a loud grade 3 early diastolic high-pitched murmur was heard, increasing in intensity with expiration and radiating up the left parasternal border, which was pointing us towards the diagnosis of aortic regurgitation. So now then after, till now, along with this we also got the investigations done, ECG and X-ray. Then taking forward with the imaging. So as I said, if we are looking at the diagnosis of aortic dissection, it becomes very important to expedite the diagnosis and perform an imaging of the aorta, because there are some aortic dissection detection risk score is present, where if particular chest pain, typical chest pain radiating back is present, along with some malperfusion clinical signs like present in our patient, unequal blood pressure and aortic regurgitation murmur. So these are high-risk features for a patient of aortic dissection, and therefore imaging has to be performed as early as possible. In emergency, the readily available imaging we have is the 2D echography. First view form. This is a 2D echography of a subcostal view showing abdominal aorta. This is the flap, the abdominal aorta, seen flowing with the blood. Then I performed transthoracic echography, parasternal long axis view, of same patient, kept the probe on the chest of the patient parasternally on the left side. This is showing the, first I'll tell the normal anatomy. This is left atria. Through the mitral valve it is going into the left ventricle. Then through the aortic valve it is going into the aorta. This is the aorta. So this red blood which is going from the aorta into the left ventricle, that is showing a jet of aortic regurgitation corresponding to the murmurs. This is showing that aortic regurgitation, moderate to severe aortic regurgitation is present in our patient. This is a short axis view showing left ventricular hypertrophy and no regional wall motion abnormality is present. This is left ventricle. This is the interventricular septum. This is the anterior border. This is the lateral wall, and this is the inferior wall of the left ventricle. All walls are moving properly. No regional wall motion abnormality is seen in this short axis view. This is again a parasternal long axis view without the color imaging, showing a dilated aorta and probably a flap. A small flap can be seen in the ascending aorta. This flap moving in the loop.
So the aortic root is spared. Where did the flap begin? Can you figure that out?
The root is regurgitating because regurgitation is there and dilatation of the root is there, so the root is involved and flap we can see is present here in the proximal aorta.
The aortic, the coronary, ostia are spared.
So that is not will not be seen on 2D ecography. That would be seen on a more sensitive investigation like transesophageal echo or CT.
It can be seen.
Indirect evidence is that there is no regional wall motion abnormality. That means the coronaries are not escaping. They are not like closed. They may still be involved in dissection as they were, but means it's not. They are not closed.
Now they are not closed. If dissection flap extends, if blood pressure not controlled properly, then they may involve.
Anything else you would like to say on transthoracic echo, which has significance?
Sir, not sure. In this, in a short axis view, when you sweep and see the aortic valve, morphology of aortic valve should also be commented upon.
Now, what about the pericardial effusion, and why is that important?
So, because in acute aortic dissection, if it is involving the root of the aorta, aortic rupture and tamponade and effusion can take place.
Yeah, pericardial effusion is a bad sign, and you have to take the patient straight to OR.
Also, the morphology of the aortic valve is to be commented upon by the aortic valve because predisposes to certain conditions.
Yes, okay.
So, echo findings were concentric LVH without any regional wall motion abnormality with normal ejection fraction. A dissecting flap was seen starting in ascending aorta and extending at least up to the abdominal aorta, and moderate to severe aortic regurgitation with a tricuspid aortic valve without any pericardial. So to make the diagnosis first, so diagnosis of aortic dissection has been made. To classify it, a small slide about the classification of aortic dissection. Diagnosis of hypertensive aortic dissection of Stanford type A, DVT type 1 was made, and with moderate to severe aortic dissection was done. So this is the type A aortic dissection, which more often than not requires surgical intervention to repair. Also because it is involving the aortic valve, so that also has to be replaced. In some cases, it can be done endovascular management if the patient is not suited for surgery. But because we have a CTSP, so management done in ER was that for pain management we gave fentanyl and 50 micrograms, and for blood pressure management, the target blood pressure that we have to maintain so that the aortic dissection plan doesn't extend is systolic blood pressure has to be maintained between 100 to 120 and heart rate has to be maintained below 60. So the best drug to the one that is showing the proper blood pressure. So the drug of choice to maintain these targets are beta blockers. Esmolol has to be preferred, but readily available in emergency laboratory also we use laboratory. 20 mg ISAT was given because it has both alpha and beta blocking activity to control both heart rate and blood pressure. And then infusion was started at 1 mg per minute. After that, CTS consent was taken and patient was shifted to CTS consent. So now I would like to call upon Dr. Saurabh to receive the patient in answer.
Good morning. I'm Dr. Saurabh Gupta from Department of Cardiac. So this patient was shifted to CTS ICU on the very same day, around 3:30 p.m. Initial ABCD assessment for already done in the ER. So vitals at that time were heart rate of 72, BP 55 by 29 in the right arm, and 143 by 51 in the left arm. Patient was shifted on oxygen with a saturation of 95%. He was comfortable. There were no signs of malperfusion at that time. And the provisional diagnosis was Stanford type A with DBP type 1 aortic dissection. There was moderate to severe aortic regurgitation. Ejection fraction was normal and patient was in normal status. So the plan was to stabilize this patient with the following targets. Heart rate was to be kept at around 60 to 80 per minute. Systolic blood pressure around 100 to 120 in the arm which was showing the normal pressure. Saturation of more than 95% and with a hemoglobin target of around more than 12%. So we started him on an ECG monitoring. Invasive arterial blood pressure was taken on the left radial artery, pulse oximetry and urine output. We discussed this patient with Dr. Cheshti because it was a type A aortic dissection, so surgical intervention has to be done in this patient. So he suggested us to do a CT aortogram to take a complete picture of the ascending aorta and the thoracic aorta and the descending aorta, and to know the extent of the flaps of the dissection. Depending upon that, he has to revise his surgical plan. The routine lab investigations were sent. So to manage this kind of patients, the aortic dissection patient, this is an anti-impulse therapy is given. So what actually anti-impulse therapy is that this is a normal arterial pressure waveform of the patient. If you do an invasive arterial blood pressure monitoring, this kind of arterial blood pressure waveform is seen. And this initial upstroke is by the left ventricular ejection. So there is change in the pressure and it takes some time. So dP is the change in the pressure and dt it is the time that is required to change this kind of pressure. So dP by dt is actually the upstroke of this arterial impulse. So what anti-impulse therapy is all about is to decrease the dP by dt. So this dP by dt creates shear stress. This shear stress further deteriorates the dissection and increases the dissection flap. So we have to decrease the dP by dt so that we can limit the further further spread of the dissection flap. So it is defined as reducing the blood pressure and more importantly decreasing the rate of the change of the shearing forces also. That is decreased by dP. So that I already discussed that dissection progression depends on the strength of the pulsation of the LV, that is the initial upstroke of this arterial trace waveform, and all the medications that decreases the inotropy, that is they decrease the dP, and negative chronotropic effect, that means they slow the heart rate. So this dt will prolong and further dP by dt will be decreased. So ideal choice is beta blocker to achieve this goal. So beta blockers are the drug of choice. They moderately reduce the blood pressure. They have a negative inotropic action and dP by dt is reduced. So I have compared these three arterial waveforms. This B1 is the normal arterial waveform which we receive in a patient, and if we are starting on beta blockers, this C waveform is for a beta blocker. So this dP by dt, that is the upstroke of this ascending limb of the arterial waveform, is decreased. This is by the beta blockers. And beta blockers, the choice of beta blockers is esmolol and labetalol, is already discussed. And if we starting on sodium nitroprusside, some people say that decrease the blood pressure. So SNP, sodium nitroprusside, is a potent arterial and venous vasodilator. So if we starting on sodium nitroprusside, it will profoundly decrease the blood pressure, but there will be compensatory reflex tachycardia. So this tachycardia will actually increase the dP by dt, and the upstroke of the arterial waveform will be quite increased, and that will further increase the shear stress as well as spread the dissection flag more towards the descending thoracic aorta. That has to be avoided. So the best practice is to start with a beta blocker, and if your blood pressure is still not achieved, we can add some sodium nitroprusside or an anti-J infusion to achieve our desired targets. So in this patient, we also gave injection panthenol 50 mg IV bolus for pain relief. Invasive lines were put: left radial artery 20 gauge, left internal jugular catheter, a 4-lumen catheter in the central venous line, a white bore 16 gauge IV cannula, and laboratory infusion we received from emergency. So we continued at 2 milligram per minute, and sometime the pressure was still not controlled, so I added SNP infusion also for quite some short time. These are the additional findings. When I was preparing the patient for left internal jugular vein cannulation under sonographic guidance, so I saw a flap in, this was from the left side. There was a flap. This is the IGV, and this is the 4-lumen catheter which is showing, and this is the flap in the carotid artery. This is the left carotid artery. So looking into this, I was pretty sure that there must be some flap in the other carotid as well. So I did the same on the right side also, and there is a flap which is formed on the right common carotid artery. And since there was difference in the blood pressure in the bilateral lower limb also, so I did a vascular ultrasound of the right femoral artery. Here you can see a flap. This is the false lumen which having a thrombus, and this is the true lumen. This is the femoral vein, and on the left femoral artery also you can see a flap here also. So now I was sure that it was a Stanford type A dissection, DPK type 1, with the flaps extending on bilateral carotids and the bilateral femoral arteries as well. This is a figure which is actually taken from the intraoperative transesophageal ultrasound, echocardiography. Here you can see clearly a flap. This is the aortic valve, this is the aorta, and there is a flap in the ascending aorta. When we put color Doppler, you can clearly see that there is severe aortic regurgitation at that time. Here is the severe aortic regurgitation. Here. This is the severe aortic regurgitation. Almost all the stroke volume that is going into the aorta is coming back with the dissection flap. So next day the patient was hemodynamically stable with labetalol and SNP infusion. Heart rate was 59. Blood pressure on the left radial artery side was 118 by 29. 98% saturation of 2 liters of oxygen. Respiratory rates was 16. CVP was 8. And our final diagnosis was Stanford type A aortic dissection, DPK type 1, with dissection flap in bilateral carotids and bilateral femoral arteries. There was moderate to severe aortic regurgitation. Ejection fraction was normal, normal coronaries, and normal sinusoidal. So I would like to invite Dr. Ashish Sharma to present the cardiac process.
Thank you, Dr. Saurabh. Let me take it from here. Now the next step was to establish the diagnosis, which I like to highlight that it requires a high index of suspicions with the history and thorough physical examination, studies like ECGs and routine labs. In history, as they have already told you, the risk factors for acute aortic syndromes, which we have to remember, is like bicuspid aortic valve, atherosclerosis, connective tissue disorders, a known aneurysm, arteritis, cocaine abuse, hypertension, pregnancy, or previous cardiac surgery. A possible physical examination which we see in the features of Marfan syndromes and cardiac tamponade, neurological deficits, any development of bruit, visceral ischemias or limb ischemias. Imaging studies they have already told you about, like chest X-ray, CT, echo. And the basic what I want to emphasize is the role of CT. It establishes the diagnosis if in doubt. Assessment of branch vessels can be done in a CT, and which shows us the entry tear, re-entry tears, and malperfusions. So the guidelines were if the patient is stable, one can do a CT angiography. If patient is unstable and diagnosis is in doubt, then we intubate the patient and do a transesophageal echocardiography. If the patient is unstable or diagnosis confirmed, the patient can be directly taken to the OR. This is a CT of the patient, CT aortogram, which clearly shows us the flaps from the ascending aorta going all the way down to the abdominal aorta. This is the CT showing the flap and surrounding thrombus. Flap is also in the descending thoracic aorta. And in this view, the flap is going all the way down. Now the surgical part. The aims of our surgery is that we replace the part of the aorta that has the entry tear with a Dacron tube graft. we depressurize the false lumen or replace or repair the aortic valve if it is incompetent, or reimplant the coronaries if the aortic root is being replaced, and take care of the malperfusion, of course. The problems are that dissected patients are often desperately very ill with hemodynamic instability and some sort of organ dysfunctions, and dissections are often brought in ungodly hours. The arterial access for cardiopulmonary bypass has to be other than the ascending aorta, because ascending aorta is already dissected, unlike non-dissected cardiac surgeries, and tissues are very fragile and it's very tricky to make a suture line hemostatic. Laboratory studies possibility are that we have to follow them actually. If there is leukocytosis, it's always due to a stress state. Falling hemoglobin and hematocrit, we have to take this into account because it may indicate that there is a leaking aneurysm or a rupture, or if urea creatinine rises, then renal artery involvement, cardiac enzymes rise, coronary artery involvement, or if there is LDH rise, then it can denote as a hemolysis in the false lumen. FDP is the recent test, which is if more than 12.6, it suggests high possibility of dissection. What we do in surgery is we perform a Bantal's procedure. In this, we see that this is the diseased aorta, dissected aorta with the coronary. We replace it with a tube graft with valve in situ, and coronaries are implanted into this tube graft. This is the graft which we usually use, and this is the valve at this downside, and coronaries are implanted on this tube graft like this. In these patients particularly, we have a problem that we have to choose the arterial inflow, because femorals are dissected, or right upper limb already showing low pressure, so we have chosen right axillary artery exposed, left axillary artery is exposed, and because of the size is small, first we have to put a graft in it, and then we insert the arterial cannula in the left axillary artery. These are the coronary buttons, a diagrammatic representation which we made, and we make a hole in the lower end of the graft and anastomose these coronary buttons to the graft. And this is a very skilled procedure, because these coronary grafts, these tissues are very fragile. They are exposed to kinking, stretching, or twisting, which directly lead to myocardial infarction on table. In this way, we take the sutures at the lower end from the annulus, aortic annulus, to the valve, and we slide them down and fix it like this. And in the distal anastomosis, we suture this tube graft to the distal aorta. Obviously, this distal aorta must be having two flaps, and a true and a false lumen. So while taking the suture, we'll take the false lumen into the account so that the false lumen closes. And then when the blood is once restored from the true lumen, then all the flap is restored. This is when we open the patient. As we see the aorta, this is the aorta which is bruised, inflamed, grossly dilated. We take a very utmost gentle care for dissection. We have to reach till the arch, and it goes very slowly. And this is what, when we open the aorta, now the aorta is open, and we see a flap with a thrombus all around the aorta in the false lumen, and this is the hole. And now we are going to see the intimal tear. And this is the intimal tear in the ascending vertical. These are the coronary buttons which we are talking about, and we have made a hole in the lower end of the graft, and these coronary buttons are sutured to this. This is the final picture with the graft in situ, valve in situ, and there is no leak or blood coming out. Total duration of the surgery was 6.5 hours. The total cross clamp aortic time was 3.5 hours, and total bypass time is 4 hours. Post-operatively, patient did well. He shifted to CTS ICU with stable hemodynamics on normal doses of inotropes. Blood pressure difference normalized immediately after surgery. Patient was extubated on post-operative day 1. There were 3 drains in total, 2 mediastinal and 1 right dural. Initially with a bloody output, but soon they are converted into serous from POD 1, and drains were removed on the post-operative day 3. Patient was off inotropes by the third post-op day, and urinary catheter and central line were removed on 5th. Patient was discharged on 7th post-operative day with antihypertensives and warfarin, and reviewed in OPD after 2 weeks, and he was doing well. This is the patient at the time of discharge. And some theory part is like aortic dissection arises from a tear in the intima, exposing the medial layer to the pulsatile blood flow. There is progressive separation of the aortic valve, which results in the formation of a false lumen and a subsequent progression. Incidence is 1 to 10 cases per lakh population per year, and aortic dissection is the most common.
Ashish, we are already finished our time, so I think we will skip that.